Hello and welcome, everybody. I'm Kamran Abbasi, Executive Editor of the BMJ, and I'd like to welcome you on behalf of the BMJ and our co-conveners, George Davey-Smith of the University of Bristol and Dr. Allyson Pollock of the University of Newcastle, to our latest COVID Unknowns webinar. Today's session will focus on the hotly debated topic of zero COVID. Now, the COVID unknowns concept originated in an article by George Davey-Smith in the BMJ last year, in October of last year, and that was swiftly followed by an all-day event in November, which attracted a considerable global audience and interest. And it was clear to George, Allyson, and Fiona Godley, our editor-in-chief, who unfortunately can't be with us today, that there was a real hunger for this type of event. And we initiated a series of 2-hour events every couple of weeks, each of which has focused on a specific aspect of the pandemic. So far we've had schools and children, testing, and vaccines. And in the weeks ahead, we'll be looking at new variants and long COVID. But today's topic is, as I said, zero COVID. We've got a wonderful panel with some fascinating presentations, and I will now hand you over to our Master of Ceremonies, Phil Hammond, to introduce the first session and lead us through this. Phil.
Thank you very much, Cameron, and welcome one and all. We have thousands of participants again logging into this, and you can watch it again on the BMJ YouTube channel if you don't get a chance to watch it live. So please share with your friends. The hashtag COVID unknowns, if you'd like to tweet, is always welcome. And we answer your questions. Put a name to who you are on the Q&A thing. We'll get through as many questions as we can. I'm an NHS doctor and a journalist, and I'm going to put my hand up and say, I'm not sure what zero COVID is. Not sure what the definition is. I've got about 100,000 Twitter followers, and I appreciate this isn't scientific, but I put a few polls up, dodgy polls. My first one was, zero COVID is highly unlikely, possible with huge effort, or confusing and poorly defined. 51% of over 1,000 people said highly unlikely, 28% said possible with huge effort, and 21% said confusing and poorly defined. So I did another slightly loaded question. Zero COVID may not always be possible, but the countries that aspire to it have done better in managing the pandemic. 82% agreed with that, and only 18% disagree. So even if we don't know what zero COVID is, maybe it's easier to launch a public health campaign around it and manage the pandemic better. Who knows? Hopefully we'll discover the answers to those coming up. First up, delighted to welcome Art Reingold from UC Berkeley, who's going to be talking about strategies for infectious disease control. Over to you, Art. Oh, is Art still here? You here, Art? I can just not see you yet.
Can you hear me now?
We can hear you now, Art. How are you? We need to see you as well.
Can't. I'm having trouble with my computer.
How are you, by the way?
How am I?
Yes.
I'm fine, but maybe, can you see my slides?
I can't see them at the moment.
No. Just a second, sorry. Shoot. All right, here we go, sorry. That should do it. And now can you see them?
I can see you at the moment, Art, but not the slides.
You can't see the slides now?
No, just got you, so maybe you can.
One more try. Sorry, I don't mean to take up time here. I'm screen sharing, it says.
Would it be easier if we got Nikki to put this?
Could you, maybe you could do that, sorry.
Nikki, could you put the slides
My
up?
sincere apologies. I had them up. Let me see if this works. One more attempt.
Yep.
Ah, there we are.
Well done.
Good. Okay, go to full screen here, if I can. How's that?
Great.
Good, sorry. So in any event, thank you very much for inviting me. I think it's a highly relevant topic, given it was a year ago this week that the Director General of the World Health Organization declared COVID-19 a public health event of international concern. And obviously a great deal has happened since then. In my few minutes, I'd like to just lay out some terms and concepts, and particularly relevant to what we just heard about what does zero COVID mean. And of course, I'll be only skipping over a few of these concepts. So I just want to point out that back in 1998, something called the Dahlem Workshop on the Eradication of Infectious Diseases, which is all summarized in a very slim volume, defined a number of terms that I stick to these definitions, although most of the world at this point seemingly considers them somewhat indistinguishable, which I think is unfortunate. So just to talk about these general concepts as laid out in that foundational document, here you can see the control of an infectious disease relates to basically reduction of incidence, prevalence, morbidity, et cetera, as a result of deliberate efforts, but that intervention measures are required to maintain this reduction. And control also relates to what is considered locally acceptable. Elimination at that point was defined as a reduction to zero of the incidence of the disease in a specific geographic area, such as a country or region, but that continued measures would be required to keep it at zero and prevent reestablishment of transmission. And eradication was defined as a permanent reduction to zero of the worldwide incidence of an infectious disease caused by a particular agent as a result of deliberate efforts, and no intervention measures are required any longer. And I would simply point out that most people now use elimination and eradication interchangeably. They talk about global elimination, which is fundamentally eradication, and they talk about global eradication, which is basically redundant if you stick to these definitions. And then the last thing that was defined was extinction, which was that the specific infectious agent no longer existed in nature or in the laboratory. And so when we think about whether a disease can be eradicated globally or not, we have to consider the various epidemiologic features of the disease, whether they're non-human reservoirs, how easily it's spread, something about the naturally induced immunity, and things like that. We need to take cognizance of the interventions that are available, the effective interventions. And preferably, it's good to know that elimination in a particular area was feasible before deciding to move to eradication. It's also important to have political will and support of the population, that a disease is important, that someone will pay the costs of eradication. It's preferable if eradication can synergize with other interventions. And there should be a compelling case that eradication is better, if you will, than simply ongoing control. So here's just some example. I think everyone knows that currently extinction in terms of a human pathogens is really only considered feasible for smallpox, but eradication using existing tools is considered possible for polio, measles, rubella, and dracunculiasis. And I would point out that in the case of dracunculiasis, that's without a vaccine. It's not using a vaccine for eradication. And then there are other diseases that are considered plausible to eliminate either infection or disease, or perhaps only to be able to control the disease, such as shown here, tetanus and cholera and schistosomiasis. And I'm sure we could debate what goes in what column, but that's typically what's thought. I will point out that in the past, there have been a number of attempts to eradicate infectious diseases that failed. Yellow fever and yaws and malaria all failed for a variety of reasons in the eradication efforts. And so far, we've eradicated 2 infectious diseases, one in humans, smallpox, and one in cattle, rinderpest. So far we've got 2 we've eradicated, and people are working really hard on polio. I won't get into details about this, but when we think about how we might achieve elimination or eradication or control of a disease, we have to think about all of these various things that are shown on this slide. Not time for a lot of detail about this, but knowing this is really important in considering prevention and control and elimination and eradication strategies. And as I'm sure many people on this call are familiar with, we can talk about different modes of transmission that are basically broken out here. And of course, for COVID-19, there's been an evolution in our understanding so that we now understand that COVID-19 is overwhelmingly transmitted primarily through the airborne and droplet routes, and probably not to any great extent through other mechanisms. And then when you think about how you can reduce transmission of an infectious agent, in a chapter that I co-wrote with a colleague, we laid out these 6 basic approaches that allow us to reduce transmission. And you don't need a model, if you will, in order to understand these. You can reduce contact between potentially infectious individuals and susceptible individuals. You can reduce the probability that potentially infectious individuals are in fact infectious. You can reduce the susceptibility of susceptible individuals, reduce infectiousness of those who are infectious, interrupt transmission from infectious to susceptible individuals, and reduce the fraction of the population that is susceptible. All of these map to one or more control measures. Many of the ones that are commonly used for different infectious diseases are shown here, but for the sake of time, I'm going to skip to the one that lists what types of prevention and control measures are being used currently for COVID-19. And these include, of course, protective gear for healthcare workers and isolation of cases, quarantine of exposed individuals, cordon sanitaire and protective sequestration basically relate to sealing off populations so that there are no people going back and forth from an infected to an uninfected area. Of course, masks and facial coverings, travel restrictions, social distancing, hand washing, environmental decontamination, which probably has little to do, if anything, with control of COVID-19, possibly the closing of live animal markets, not clear to what extent that's being done, and now within the last few months, vaccination. So in preparing this talk, I had to familiarize myself with the Zero COVID Alliance because I haven't seen it mentioned here in the United States. I'm sure it's because I'm not on social media. But in looking at the website, I came up with several definitions, if you will, or goals of the Alliance. One was a goal of getting to zero transmission. One was to stop the spread of COVID-19. And one was a world with zero COVID. So I would agree with the person who introduced all this, Phil, that these are not necessarily consistent messages. They don't all mean the same thing to an infectious disease epidemiologist. At this point, I just want to point out that in my world, people often talk about transmission of COVID-19 when what they really mean is transmission of SARS-CoV-2 virus. COVID-19 is the disease, but the infectious agent that's being transmitted is SARS-CoV-2. So I don't talk about transmission of COVID-19, and I think that can be somewhat confusing. So in summary, in my introduction here, I want to ask the question, what does zero COVID mean? And Phil, I think, raised this issue already. Does it mean a global absence of COVID-19 cases in humans? Does it mean a global absence of SARS-CoV-2 transmission between humans? Does it mean a global absence of SARS-CoV-2 virus? Or does it mean something else? And I think it's really important to get this straight because I think the discussion that's going to follow would be very different depending on which of these definitions we mean. And I just want to end with this cautionary afterthought from one of my former students in Brazil, who was quoted recently, as you can see here, basically making the point that we can't achieve eradication, that is, a total absence of the virus globally, if the virus is still present in one or more locations. So that's the difference between elimination and eradication, and it presents quite a challenge for this virus. So I will now listen with interest to what my colleagues have to say about this really interesting topic. And thank you for inviting me.
Thank you very much indeed, Art. That set up the discussion beautifully. If you want to ask questions, there's the Q&A button at the bottom of this. Please give your name as well, but we'll answer them at the end probably. We're going to move on now to Helen Ward, who is chairing a fascinating session on for and against zero COVID, whatever it means. Over to you, Helen.
Thanks very much, Phil, and thanks to Allyson and everybody for organising this session. So yeah, I'm sure I share much of what has been said already by Phil and Art. Actually, I'm really looking forward to finding out a bit more about what these are. I don't suppose there's anybody here who wouldn't like to have zero COVID, whatever it means, that would like to actually control this virus and indeed the disease. So I'm looking forward to this debate. Now, we have a debate here which is for and against zero COVID stroke elimination. And we've got Deepti Gurdasani from QMUL and John Ioannidis from Stanford University speaking. And in apparently no particular order, I'm going to call Deepti first for 10 minutes to put her side of this no doubt heated debate. Thank you, Deepti.
Can you see my slides?
We can, if you can put them on. Yeah, brilliant. Thank you.
Great. So, I know this is a session on known unknowns, but I'm going to argue that zero COVID is really important because it's actually one of the few known knowns we have in the midst of a really uncertain and dire pandemic. So what is zero COVID? We've heard about a few definitions, and I'm just going to define upfront what I mean when I talk about zero COVID. My understanding is that it's getting cases down to zero or near zero levels in the community. So what you're bringing down is community transmission to zero in a way where they can then be contained within that region with active surveillance and rapid response as and when cases arise. And as has been said before, I think really well by Professor Reingold, elimination is not eradication. So we don't mean getting rid of the virus entirely globally. And it's important to say this up front because this has been sort of used as a straw man argument prominently in discourse, including scientific discourse, saying that it's unachievable because eradication for most infectious diseases has been unachievable. So there's no point trying. But I'm going to argue that ultimately trying is much better than not trying at all, because even if we don't manage to achieve elimination, we will still protect our health, the economy, and society much better than if we hadn't tried at all. So I just want to say, first of all, that it has been achieved. So, there's a lot of evidence about this. This is not a fantasy. It's a reality in many countries. Up to 30 countries have now achieved zero COVID, and 15 more countries are close to achieving it. So they have less than 500 cases a day at the moment. And approximately 23% of the world population is now living in a zero COVID region or a region that's very near zero COVID. So this is not a fringe or exception as it's been portrayed very often in the media and even in scientific discourse. It's very much the mainstream strategy in many countries and many parts of the world. And here's just a list of a few countries that have achieved this. It makes it very, very clear that it's not just one or two examples. There are multiple examples of this. So I think the big question is, why should we aim to achieve this at all? And the biggest argument for this is protecting our health. So for example, this is up-to-date data from across the world, and we can see that countries that have aimed for or achieved zero COVID have had far fewer deaths compared to countries, particularly in Europe, the United Kingdom and United States, which have used a strategy of halfway measures, balancing public health and the economy, which have sadly led to hundreds of thousands of deaths. And one of the other arguments for zero COVID is actually to protect the economy. I think for a long time, there's been a false dichotomy between, getting on top of COVID and protecting the economy. But it's very clear that countries that have managed to get on top of COVID, have pursued zero COVID, have actually had the least hit to the economy versus countries like the UK, where balancing public health with the economy actually led us achieving neither protection of public health nor economy. And one of the biggest arguments, I think, is also to protect society. So, people have sort of compared zero COVID to being associated with less freedoms, less liberties, huge impact to society. This is simply not the case. Let's just look at these two pictures here. So this is United Kingdom in our third lockdown. And here is a picture of New Zealand with people attending a Super Rugby game. And just look at the number of restrictions we've had. In the UK, we are now 5 months in lockdown and ongoing. We've been at least in some level of restrictions for the last year. Whereas in New Zealand, elimination was achieved within 65 days, 5 weeks of lockdown. And in terms of education and society, we've had school closures for 16 weeks. And even when schools were supposed to be fully open, they weren't to many students because of high levels of absenteeism. New Zealand, education has been largely undisrupted except for about 4 weeks of school closures when they were in lockdown. So what are the consequences of failing to control the pandemic and not pursuing such a strategy? Let's look at the UK, where this was considered impossible. And we pursued a strategy of halfway measures. We now have over 140,000 deaths certified as linked to COVID-19. We have an economic recession. We have high levels of unemployment, hundreds of thousands of children in poverty. We've been in restrictions for almost a year now. Huge disruption to children's education, leading to increase in disparities and inequities, and high absenteeism in schools, even when they were open, disproportionate impact on more deprived communities, particularly ethnic minorities, and of course, impact on women on whom the caring burden has disproportionately fallen. So how do we go about achieving zero COVID? Thankfully, because it's been achieved in many countries now, we know that there's a clear path to this that has been tried time and time again and has met with success. So the basic key principle is bring cases down to zero, near zero, and then keep cases down. What we need is, first of all, clear public health messaging upfront of the long-term strategy and the path so that we take the public with us, bring cases to zero or near zero with non-pharmaceutical interventions like the ones that were outlined earlier, along with vaccine rollout continuing, set up effective test, trace, isolate systems so that as and when cases occur after they come down to zero, we can quickly get on top of them, stamp them out before they spread into the community. The key part of the elimination strategy is that we don't want community transmission to become established. And we also need comprehensive border restrictions and managed quarantine, as has been implemented, for example, in Australia and New Zealand, so that we don't import infections once we bring them down to zero. And we establish green zones with other countries that have managed to eliminate so that we can have travel corridors with them. I'm going to talk about a few myths around zero COVID that I've commonly heard and try and debunk some of these. So one of the common myths is only island nations or small countries can achieve this. So just want to show here that this is a global picture of sort of the number of daily cases that we are having per million people. And I just want to show that this has been achieved in many countries in Europe, Asia, Africa, and Australia. And they are countries that are very, very different. They're not all island nations. Some of them are really large, like China, which was actually the epicenter of the outbreak, Vietnam, Australia, Taiwan, Thailand. So there are numerous examples who have a very different setup, very different population density, very different populations. The other myth that I've heard, particularly in the UK, is we're too culturally different. It works in Southeast Asia, it wouldn't work here. But I want to highlight here that actually public messaging is a key part of this, and public support for restrictions and lockdowns within the UK at points of high transmission has consistently been high. The public have wanted earlier lockdowns. They wanted lockdowns to continue, not be eased early on consistently. And adherence with lockdown, despite what we hear in the news, has been very, very high. And where adherence has been low, for example, in compliance with isolation, it's been due to practical factors such as lack of financial support with isolation rather than people not wanting to. And the other myth that I hear is it requires a much longer lockdown. People will get tired. It'll impact the economy. We can't accept this. But actually, that's not the case at all. We need to remember that early action means shorter lockdowns. And if you look at the duration of lockdowns in different countries that have achieved zero COVID, what they did was act early. So New Zealand, this was achieved in 5 weeks. Taiwan actually didn't have a lockdown at all, and neither did Vietnam. They didn't have a national lockdown. They had targeted lockdown in places where they needed to get things under control for short periods of time, usually 2 weeks. And just to show that this was entirely achievable in the UK during our the first wave and the second wave. So here's a graph in the UK showing the first wave and where we were on the 13th of May when we started easing lockdown. And had we actually not eased lockdown at that point in time and continued with the same R rate, we would have achieved zero COVID by about July. And that would have meant that hopefully if we had a fixed test trace and isolate system, we would have identified any new outbreaks quickly and stopped them out. And also we wouldn't have had to deal with a new variant that arose, which was closely linked to this huge second surge of infection that we saw. Of course, we missed that opportunity, but even now, looking at the surge in cases during the second wave, we can still achieve zero COVID if we don't start easing lockdown too early. And if we continue with an R rate of about 0.8, which is where we are now with the current number of cases, this is something that again could be achieved within 2 months. So even with a high level of cases, it's achievable in a matter of months. But also want to point out that had we acted early and prevented cases getting to the point that they have been, we could have actually achieved this in a much shorter period of time. So if it's going to take longer now, it's only because we acted late. The other myth is that it means travel restrictions indefinitely. This is something that's repeatedly been said, but when do travel restrictions end? So we know already that there are travel corridors between countries that have eliminated. So if you have regional coordination, you can open up travel corridors with regions. New Zealand has already announced that it plans to roll out the vaccine to the full population and then plans to reopen its borders. And we need to remember that much of Europe has been in travel restrictions for almost a year. And even when these were removed, they had devastating consequences. We know in the UK alone, there were at least 1,000 different introductions of infections over the last summer from genetic analysis. So, it's not that if we don't have zero COVID, there won't be travel restrictions. And we know that the UK now has new variants that are more transmissible, potentially more fatal. And even if we did want to travel to other regions, there are travel bans now in place because the UK has become the epicenter of a new outbreak of infection with a dangerous new, more transmissible variant.
Can I ask you to wind up now, please, Deepti?
Sure. So another myth is that, ultimately things will be the same. These nations will suffer the same losses we have suffered. But I think we need to remember that there is no evidence for this. The divide between zero COVID and non-zero COVID countries has actually widened over time. Here is just a list of different countries and the number of deaths that they've had versus the number of deaths in the US and UK. And I don't think I need to go through this for you to see the huge difference. One thing I really want to stress is the idea that we don't need zero COVID because now we have vaccination. There's a huge amount of uncertainty with vaccination being the sole strategy for elimination. First of all, can elimination be achieved with vaccines alone? There's no certainty around this. Even if we vaccinated everybody eligible, there's a large proportion of the population that's not eligible at the moment, particularly children. And of course, we don't know what level of uptake there will be in the population. We don't know the duration of immunity with new variants. We don't know about effectiveness against these. We also know that the herd immunity threshold is likely to be higher with more transmissible variants. So can this be achieved? And of course, we know that vaccine access isn't uniform across the world and many countries don't have enough vaccines for their population. But also the question is, if it could be achieved, what would the cost be of high transmission during rollout? And this is a study by Imperial that shows even with vaccine rollout continuing at a very optimistic rate, between 3 to 4 million a week, we would still see at least 30,000 deaths. And with new variants, this scenario is even more complicated because essentially—
Can I ask you to please wind up? I'm afraid you're—
Sure. So I just want to say that allowing high levels of transmission to continue alongside giving vaccines allows adaptation, and that creates even more uncertainty. So I just want to show these figures here to say this is where the alternative has led us to zero COVID. And rather than asking the question about why we should be pursuing zero COVID, we should be asking, why have we not so far, and why are we still arguing against it? That's all from me. Thanks.
Thank you so much, Deepti. That was an excellent exposition. And so I'm really looking forward to hearing what John Ioannidis from Stanford is going to say in response to that. And if there is time, we may take one question at the end of this session. So John, over to you.
Hello, thank you for the very kind invitation, and many thanks to Deepti for the very insightful first commentary on this topic. I'm not sure I can match that, but I'll do my best. To start with a disclosure, I have no conflicts of interest. I have no personal Facebook, Twitter, or other social media accounts. I have not signed any petitions, declarations, memoranda, advocacy statements for zero COVID, against zero COVID, Great Barrington, Jon Snow. These have been signed by amazing scientists and great colleagues and wonderful friends, but I haven't done that. Some preemptive comments. I love zero COVID in the same way as I love zero cancer, zero tuberculosis, zero starvation, zero any disease. The question is, can we achieve this? Will efforts to achieve it reduce or increase SARS-CoV-2 deaths as well as overall deaths and the burden of total, not just SARS-CoV-2 related disease? And aside, how many other diseases have we managed to eradicate entirely? Tuberculosis, malaria, syphilis, and yaws. We have tried with all of those diseases with animal reservoir and with many subclinical infections. We must be kidding. Now, if zero COVID is near zero, I'm 100% in agreement with Deepti, but we have to define exactly what we mean by near, because near has quite some range. Is zero COVID, no matter how we want to define it, is it up to us or is it up to the virus? And I'm not talking about New Zealand, I'm not talking about Vietnam, I'm not talking about Taiwan, that did a wonderful job and did exactly what I was saying a year ago. Test, test, test. That's what the WHO was saying, and then isolate and contact trace. But now the horses are out of the barn. Is it up to us where the SARS-CoV-2 will become, actually already is endemic, and what its severity and total burden will be in future seasons in countries where it has become endemic? Why am I saying this? Well, we have 120 million documented cases globally and about 2.6 million deaths. This is horrible, completely horrible. This is 0.033% of the global population, but approximately 2 billion total infections have happened. We have about 20 to 25% of the global population that has already been infected. Perhaps 2 to 3% has been infected twice during 2019 to 2021. The global infection fatality rate, if you average out across the world, is about 0.15%. It's much higher in Americas and Europe. It's much lower in Asia and Africa. It has substantial variability across locations, populations, and settings. I'm sorry for the UK. You have really done very poorly. You have among the highest IFRs in the world. Approximately 1% of the global population has been fully vaccinated, and approximately another 2% has received one vaccine dose. We need more of that. We're pushing for that, but it will take a while, but hopefully we will get to much higher levels. Most people agree that coronavirus SARS-CoV-2 will become endemic, and actually probably has become endemic to a large extent to many countries. And we really don't know much about the future. There's uncertainty about immune escape, about the extent of waning immunity, about uneven vaccine distribution, about vaccine hesitancy that creates a problem, about the lack of political will, about animal reservoirs, and many, many other reasons that create uncertainty. But if you look at that paper in Science, it says SARS-CoV-2 may be no more virulent than the common cold eventually, once we reach the endemic phase. We predict a very different outcome, And could we really reach a point where we wish that next year, the season will be one with predominantly SARS-CoV-2 rather than with influenza? It sounds crazy. Ideally, of course, we want nobody to be infected. I would not wish to have that virus spread widely in the community, by no means. However, if they are infected, 40 to 70% of the global population would do better infected with influenza than with SARS-CoV-2. With better treatments, this percentage may rise to 60 to 80%. If the remaining 20 to 40% can be largely effectively shielded with vaccination and or other means, the IFR or SARS-CoV-2 may become far lower than the IFR of influenza. And in this case, might we even celebrate if a given year has a preponderance of SARS-CoV-2 than influenza infections? Is that science fiction? Well, let's take a look on why did we lose all these people to SARS-CoV-2, to COVID-19? What are the modifiable causes behind that hecatomb? Can we modulate them towards zero COVID? If we eradicate them, we eradicate also COVID-19 deaths. If we reduce them, we reduce also COVID-19 deaths. We should be aware of uncertainty about attributable fractions, of course, but we do know the main culprits. Their impact is cumulative, additive, and in some cases, probably multiplicative. And this may be good news. We don't need to succeed in all fronts. Major success in some of these fronts may have a major impact. What really caused these 2.6 million deaths is social injustice, inequalities, racism, poverty, smoking, other modifiable risk factors in lifestyle, for example, obesity, poor protection of nursing homes, poor adoption of effective public health measures, adoption of harmful pro-contagion public health measures, for example, totally foolish blind lockdowns, suboptimal and harmful treatments and medical care, and of course, lack of vaccination until recently. How many people were involved for each of those? These are rough estimates. Each of these factors affected, of course, not alone, many, many people, hundreds of thousands, sometimes millions of deaths were involved in this. Here's one example. Many people took hydroxychloroquine in high doses for treatment when they were very, very sick. The meta-analysis that will be coming out that we've done in international consortium shows about a 10% increase in the risk of death. It's if 1 million people who died got hydroxychloroquine, then we have about 100,000 deaths from misused hydroxychloroquine in that population. We know who are the people at risk. We protect them specifically. You have some example here that I'm trying to make. You have some serial killer who states his intention to kill someone. I'm going to kill people in nursing homes. I'm going to kill people who have this type of features. What do? A, you send 5 well-trained policemen to protect that person. B, you tell all 3 million people in the city to stay at home forever. C, you send 5,000 policemen to patrol random locations in the city. D, you make a sermon or a tutorial on how love should conquer hate. That's probably an easy answer to see because we have very good risk stratification. We know who is at risk. We know that it's a very small percentage of people who are at tremendous risk with like 25% risk of dying, IFR of 25%. We know there's many others who are at high IFR, and we know that there are many, many others who are at very, very low risk. So precision medicine, precision health, it was a buzzword. It was the future of medicine just before COVID. We were trying to achieve that with relative risks of 1.3 or even 1.03, for example, in genetics and genomics. We were spending tens of billions of dollars. We were sure that we will make it. And now we are saying that we cannot achieve precision shielding with COVID-19, even though we have relative risks of more than 1,000, sometimes risk ratios of 7,000 if you compare an 80-year-old who's frail against a child. So are we going to achieve effective shielding or inverse protection? We have examples that we have achieved either or the other. Singapore, a city-state with very high population density, about 60,000 documented cases, probably more than 100,000 cases, just 29 deaths, only 3 nursing homes, infection fatality less than 0.03%, probably less than 0.02%. Converse example, first wave in Spain, Belgium, and the UK, 63%, 61%, 44% of COVID-19 deaths were in nursing home residents. Nursing home residents had 2 to 3 times, perhaps even higher risk of infection than other people. And given these massacres, infection fatality rate reached or exceeded 1% in these locations in the first wave. We can do much better. For example, in nursing homes, in the second wave, we have done much better. We see a much lower morbidity and mortality in nursing homes in the second wave, and we can do much, much better, hopefully in the future with vaccination being on board. Risk factors, tobacco. Tobacco is going to kill 1 billion people in the next century, and it's happening right now, and it is in the background of the majority of people who die with COVID-19. So could SARS-CoV-2 be a covert blessing, helping to save up to 1 billion deaths over the next century? Along with Prabhat Jha from the University of Toronto, I wrote this paper arguing we have destroyed our entire world trying to get rid of COVID. We haven't really been very successful so far. Why don't we just do far less, but eliminate the tobacco industry? And that will really gain us hundreds of millions of deaths. We're dealing with an invisible enemy. This means that often we have taken blind measures. And unfortunately, most of these blind measures do not work. This is a paper we published 2 months ago. We saw that restrictive measures work, but you don't have to be more restrictive. You can be targeted, you can be focused and still work. More restrictive lockdown actually tends to increase caseload, and I can discuss about that if we have time afterwards. Which interventions work best? If you go with just SIR modeling. Different models give different inferences. We have a paper that will be coming out in Journal of Clinical Epidemiology. We use two models developed by a brilliant team at Imperial College. The one that they published in Nature shows that lockdowns work, amazingly so. The other model that they developed shows that they do not work at all. We have the problem of not causing harm. We should not cause harm. We have tremendous potential of causing harm if we don't use the proper measures, the targeted measures, measured measures. And I'm not going to go through that list because it's really very, very depressing, but we're talking about posing billions of lives at stake if we don't do it right. Can we predict what will happen? I cannot predict. If you can predict, I'm very happy, please let me know. But forecasting throughout this pandemic has failed. We have many unknowns. We have many factors. Vaccines are an amazing development, but we don't know how quickly, how successfully we can deploy them to a large segment of the population. Treatments are evolving, economic, social disruption, other public health measures, interplay with other diseases, chronic disease, catastrophic, chaotic events as people get just thinking about wars and riots and revolutions if we continue with this nonsense. Will it come back? It may. We have reinfections, but so far the evidence suggests that reinfections are not so horrible. We published these data from the national database in Austria, odds ratio 0.09 in the next season, and none of those led to a COVID-19 death. Do we know everything? We know very little still. We know far more than when we started, but there's still disagreement on important topics. And Deepti may be right. And I'm willing to go for a near zero, depending on what near means. But if we don't know, I would argue we're 1.5 years almost into this since it started, and it's going to take much longer. We need randomized evidence. We need the best evidence. A randomized trial is worth 1 million tweets. And I hope we will all agree, and I'm closing with this, I'm not sure about zero COVID, whether it can be done. Hopefully it can be done. Hopefully the virus will do us the favor, but zero life is not an option for trying without evidence and unsuccessfully to save lives. And here I need to disclose some of my real conflicts. I love fencing, and I would like to go back to doing this. And I write Libretti for opera. And I hated it when the world premiere of my opera could not be staged in November, but hopefully you can see it online on the web. Can we save lives? Can we save our life? Can we have zero COVID? Can we have zero nonsense? Thank you.
Thanks very much, John. So we've had two really excellent overviews of the different arguments, or some of the different arguments we've come up with here. But in the interests of the workshop as a whole, I am going to hand back to Phil because we are just actually on time almost. Phil.
People will be watching this and absolutely enthralled, but we do have time for some questions at the very end. So please keep them coming in on the Q&A button. We're now going to talk about country case studies. Delighted to hand over to Allyson Pollock, who's going to chair that session. Over to you, Allyson.
Thanks, Phil. Well, we've got 4 great country case studies, all delivered by experts in public health, clinicians, epidemiologists. And we're going to start with Michael Baker from the University of Otago in New Zealand.
Well, greetings and kia ora from New Zealand. And I think we've had some wonderful presentations. You've already heard a bit about New Zealand, so I'm really delighted to join this discussion. So just today, I'm going to talk about a range of response strategies. We've had a great introduction to that framework, the components of the elimination strategy, and we've heard about this, some of the benefits and costs from the New Zealand perspective, future scenarios, and a summary about the key focus of this meeting. So I think we're probably all aware of the range of response approaches. This is from a paper published in the esteemed BMJ just before Christmas, and this is the typology of approaches as we see them. I thought it was remarkable sitting in New Zealand in end of February and early March and seeing the success of the elimination strategy in Asia, and that was the approach we adopted. So we really followed the Asian model. And at the time, I remember thinking, I just assumed that this would become the dominant paradigm globally, elimination, because it seemed attainable. And so that has, I think, been remarkable to see how different parts of the globe have responded. I should say we included in this paper a definition of elimination. That was the one working definition we have in New Zealand, which is 28 days or longer without any documented transmission in the community in the presence of a high-performing surveillance system. And those definitions are in this paper here. So what are the components of the strategy? Again, these are very familiar areas. We have grouped these into three broad approaches. Obviously, exclusion of cases with good border management, good systems of case testing and contact tracing, and then a range of approaches for reducing transmission in the community. And of course, vaccination just adds another tool for reducing community transmission. And also, I think it's critical to have a social safety net to support the most vulnerable populations. So what are the benefits of the elimination strategy? Again, these will be very familiar and I think have been well summarized, particularly by Deepti earlier on. And we have observed these benefits in New Zealand, although I guess some of them are more hypothetical in terms of reducing the emergence of dangerous variants and animal reservoirs. There are broader systems benefits, and we have found that having an explicit zero COVID goal has been very motivating. I think there are real difficulties with tolerating a certain level of transmission in the community, because it's very hard to keep transmission within certain boundaries, as we've seen in a number of countries. We certainly found this has been sustainable in the New Zealand context. It does, as we've heard, it is achievable in a diverse range of settings, and it can be achieved even after intense local transmission. And in our region, we have a very good example, which I'm not going to talk about, which was in Australia, where they had intense transmission in one state, and they were able to return to elimination state with a very intense interventions. So there are obviously costs to the elimination strategy, and I think we've heard in the last presentation some of these costs, and I think we're acutely aware of the opportunity costs of putting huge resources into our elimination strategy, and obviously consequences for other health outcomes. So in terms of the impact, in New Zealand, we've had, as you've heard, very low mortality. And if we look at this in terms of actual lives saved, if we had the mortality experience of Sweden, we would have had around 6,500 deaths. And we should remember that the years of life lost per death have been estimated in a number of studies, but they're quite considerable. Not all of those dying from this infection, of course, are in particularly vulnerable groups. One of the other consequences or benefits we've seen in New Zealand has been the impact of the elimination strategy on excess winter mortality. And we have seen this basically vanish in New Zealand over our last winter, which has added another 1,500 lives saved. So these are people who would have been expected to have died last winter in New Zealand. So at this point, we can add those numbers together. We're looking at around 8,000 lives, or 8,000 people who have lived into this year who would have died if we'd had a medium intensity pandemic wave in New Zealand last year. It's already been mentioned that, in fact, with the elimination strategy, we have less time under lockdown. And this is just contrasting the experience of New Zealand, which had an intense initial lockdown for 5 weeks and then less intense for 2 more weeks. And since then, we've had a couple of pulses. We've just had one recently to stamp out small outbreaks in New Zealand. So we summarise in that paper published just before Christmas the impact of the elimination strategy on both mortality and GDP. And as has already been described, it's a false dichotomy that you're trading off one against the other. Certainly the New Zealand experience, and I think of many other countries pursuing elimination, is that we've saved lives and also the economy has performed very much better. So this approach is sustainable. This is our daily case count, and you can see that these are locally acquired cases versus imported cases. So the imported cases all wind up in managed isolation and quarantine for 2 weeks. But interestingly, of course, they add to your daily case count. We've suggested that there should be separation in the way countries report data, distinguishing between cases who are in managed isolation and quarantine, and so are not actually in the country, versus local transmission. We've already heard a very nice summary about the fact that elimination works in a diverse range of jurisdictions, so I won't say any more about that. So in terms of future scenarios, there really are, I mean, taking or building on Art Reingold's framework for where you distinguish between control and elimination. I think this fork in the road here. If we look at long-term scenarios, obviously one is long-term suppression with endemic infection and targeted vaccination. And I guess seasonal influenza is the best example. It's not a perfect example. The alternative is what we'd say is progressive elimination, reducing to zero in countries and regions, as we do with measles, and potentially global eradication. And obviously this would be a major decision that would depend on a whole lot of factors. So it's very hard to say that this would be an optimal approach. It's certainly been achieved with SARS. Obviously it was a different virus in terms of how it behaved. So I think in summary, looking at the framework here, COVID-19 can clearly be eliminated with public health measures. I think that was one of the great accomplishments last year. And I think the other major achievement in the last year, of course, has been the development of effective and safe vaccines that just make elimination easier. We think it has multiple benefits compared with suppression, and is probably the optimal interim strategy until we know whether or what the optimal long-term approach is. And obviously there are known unknowns, long-term performance of vaccines and virus evolution. The feasibility and desirability of global eradication, I think, is unknowable at the moment. And we do think, in fact, elimination should be the default option with future pandemics. Thank you.
Thanks very much, Michael. That was really wonderful. And let's move right on now to Camilla Stoltenberg from the Norwegian Institute of Public Health. Thanks, Camilla.
Hello, and thank you so much for inviting me to this event. I'll say a few words first about what has been the Norwegian strategy. Norway is a country of about 5.4 million people, and we've had altogether a little more than 600 deaths, and that means there has been no change in mortality, no increase in mortality last year. In March last year, on March 12, Norway implemented nationwide measures aiming to suppress transmission of SARS-CoV-2 as much as possible. And schools and preschools were closed, and so were universities, and a whole range of other restrictions were put in place, and borders were closed. The relaxation of these measures began by mid-April, only a month later, and priority was given to children and youth. And by early June, transmission was contained to very low levels, about 2 to 3 cases per 100,000 over a 2-week period, a trend that was observed across most of Europe and which permitted the reopening of borders between European countries in July. So, core to Norway's strategy has been the extensive use of testing, isolation, tracing, and quarantine to contain local outbreaks. And we've continued to scale up all those measures all along during the pandemic. And mortality, and we did that to prevent transmission, mortality, and an overburdened healthcare system. After the summer, Norway has, albeit at much lower levels than other European countries and with great variation within the country, experienced increasing spread of SARS-CoV-2. First, at a very slowly increasing stepwise through August, September, and October, and then with a much more rapid increase in November. So again, restrictions were put in place, and since then, they have been so more or less continuously, with some relaxation between peaks. And while the goal has been to contain transmission at the municipal level, regional and national measures have again been introduced at various time points when needed, and particularly after New Year this year. So do we have a strategy that we can call a zero COVID strategy? And how does our strategy compare to a zero COVID strategy? Clarity is needed about what is meant by a zero COVID strategy to assess how this compares to Norway's experience so far. In the context of this webinar, it is understood as an elimination strategy to achieve 0 deaths, 0 new cases, and 0 lockdowns. In other words, one strives to suppress the number of infections to or close to 0 and subsequently maintain virus-free zones by using testing, quarantine, and travel restrictions to prevent reintroduction. Along several dimensions, we can say that Norway's early response to the coronavirus pandemic, as well as key features that have been strengthened through its course, resemble that of an elimination strategy. The early and sustained use of non-pharmaceutical interventions to suppress transmission to very low levels that could be managed by the public health system. The strengthening of capacity to test, isolate, trace, and quarantine in order to contain outbreaks locally and prevent wider outbreaks and spread to other areas of the country. A phased reopening that prioritized children and youth and slowly reopened other areas of society. However, it has also in important ways departed from other countries, for example, New Zealand, Taiwan, and Vietnam, that have pursued elimination. It is here worth to highlight 2 critical aspects. One is the use of digital contact tracing tools. We started at a very early stage to develop such a tool, but did not succeed in the first place. Some countries have utilized digital contact tracing tools, which have allowed for detailed tracking of close contacts of positive cases. In Norway, however, the privacy implications of these tools exceeded what would have been allowed under current regulations. So the use of the digital tool now is voluntary. Random ID keys protect the identity and whereabouts of each user, and no additional personal data, such as bank account transactions, is collected. Neither can public authorities, such as the Norwegian Institute of Public Health, access this information, so we cannot use it for surveillance purposes. The other critical aspect is border controls. The second and perhaps most interesting aspect in the context of this webinar concerns how the borders are managed. Between the middle of June 2020 and January 2021, the movement across Norwegian borders have been relatively liberal compared to the countries that pursued elimination. At the same time, Norwegian quarantine rules, which have included the use of quarantine hotels for non-residents from early November, have been among the strictest in Europe. Since January 28th this year, the borders have again been closed for most non-residents. It is not possible for me during this short event to conclude about whether it was or indeed is realistic for Norway to pursue border controls that are aligned with an elimination strategy. However, in comparing the feasibility of strict border controls to pursue an elimination strategy in Norway, it is worth pointing to 3 aspects. One is geography. Norway shares a very long border with Sweden, as well as Finland and Russia in the north. And heavy and sustained investment in resources to control and prevent entry and secure testing and quarantine of those allowed in would be necessary and a complete elimination strategy. Now, there are very strict border controls at the moment, but they have been developed recently. The second is economic interests and connectivity. Many areas of society, for example, our health system, our fishing industry, agriculture and oil industry rely on the free movement of workers across borders. And with the current regulations that have been in place since January 29, only workers who, due to their technical expertise, are critical to the service can enter the country. So very few cross the border at the moment. And many industries are expressing concerns and are already being severely affected in the case of prolonged measures. The third is the rights and freedom of our own inhabitants. To align measures with an elimination strategy, our own inhabitants would have to quarantine and be tested in a government facility before returning to their homes. So far, those living in Norway have been allowed to quarantine in their own homes, which departs from how countries that have used quarantine facilities for this purpose have done it. A core principle in Norway's act relating to control of communicable diseases is that infection control measures must be necessary. They must have an expected benefit on preventing or reducing transmission, and they must be proportional. They must not impose a disproportional burden on those whom the measures apply to. And with respect to infection prevention and control, there is no doubt that transmission from those arriving from abroad have contributed to local outbreaks, and stricter border controls would probably have yielded infection control benefits. At the same time, such measures also impose a considerable burden.
Camilla?
I'll finish in a few seconds. It should be clear by now that an assessment of the use of strict border controls aligned with an elimination strategy is a question about trade-offs and which values should guide the decision, which demand a whole government approach to assessing the benefits and harms. It is a decision that should not be informed simply by evidence on infection control benefits of the measure, but requires the full attention across government agencies and sectoral mandates. Thank you.
Thanks so much, Camilla. And you've already answered one of the questions on border controls, so that was very nice. I'm going to pass straight on now to Chang-yup Kim, who's a professor of public health in the University of Seoul, and it's 2 a.m. in the morning, so thank you very much, Chang-yup. Do start your PowerPoint. Are you there? Yeah, great. Thank you. You're on mute at the moment, Chang-yup. And great, that's lovely.
Okay.
Yes, lovely, thank you.
Thank you very much for this kind invitation. I hope although this is the very exceptional condition for me in very exceptional time and exceptional condition, exceptional place, but I hope my presentation could be helpful in this important discussion. First of all, let me explain the title of my presentation. The similarity mean we have some common features in the healthcare and public health system, as well as the policies, with a similar cultural and social background. But we have seen divergence and differences also. I'm sure that our COVID responses are the combination of these similarities and differences. Already you would know that the relatively good performances of Korea, Japan, and Taiwan. As a couple of indicators, I will show you the trend of daily new cases, fatality rates, and economic performances. Firstly, the transmission in Taiwan is as this slide is showing, that Taiwan is the minimal and could be near elimination. South Korea is the next, and Japan is the more widespread, but still less prevalent than many other high-income countries. Case fatalities is showing a narrower gap than the number of cases, but still Taiwan is better than Korea and Japan, maybe due to the less patient burden in Taiwan. In terms of economy, the performances in this area is better than other countries. All three economies are at the left lower corners, indicating less COVID deaths and less GDP loss. As I told you just before, we have many similarities in the system and way of responses. One of the key characteristics is the role of the government in this kind of public health problem. The coordinating mechanism is centralized, and the leading and coordinating role of the central government has been functioning to some extent. Next, I believe that the insourcing is worth mentioning. It means that critical functions are mostly still in the government and public sector. For example, test and tracing are not much outsourced to the private sector, especially in case of Taiwan and Korea. We have to explore how this insourcing is related to timely and efficient implementation of relevant measures. In the practices, quarantine and border control was relatively timely and reasonable. One of the remarkable practices was the early, extensive, and persistent adoption of face masks. We are thinking that these are from the combination of several factors, including culture, citizen compliance, and literacy. Another finding is during the COVID-19 period, the trust in the government and its policies seem to be relatively high, all across the three countries. Most citizens were compliant, regardless of their social, cultural, or historical background. But as you know, the trust and compliance issue is very debatable regarding its desirability, feasibility, or some consistent application of the mainstream strategies. Another similarity is dependence on private resources, especially in the curative function. All three countries have oversupplied beds, particularly in the private sector. But due to oversupply, paradoxically, they could be relatively smoothly mobilized. I think, despite that transaction was complicated and costly than in-sourced activities, this kind of oversupply, or in another term, inefficiency, did work. We have differences also. My assessment is that one of the success factors in Taiwan and Korea is the historical experiences. In Taiwan, the SARS was in 2002, and MERS outbreak in Korea was 2015. These experiences have motivated the preparedness and capacity building in the government and society as a whole. On the overall strategies, Taiwan and earlier phase of Korea is so to eliminate, but the Japanese one was oriented to suppress from the beginning. Now it seems that future strategies are uncertain except for Taiwan. In practice, test and tracing strategies and application was different to some extent among three different countries. Japan was more decentralized, private sector dependent, voluntary, and they are less comprehensive and less ICT assisted than Taiwan and Korea. These differences related to not only public health structure, but also legal and cultural framework. Also, social distancing was less strict in the case of Japan. Now I would like to summarize the knowns and unknowns based on the experience so far. We already know several measures were effective. The centralized and coordinating function is critically important. In some cases, the capability of the local authorities was essential and still is very essential. Quarantine, border control, test and tracing, we have no doubt. In this pandemic, a comprehensive range of resources and activities must be mobilized at the national level. They include the finance, workforce facilities, equipment, supplies, and even knowledge. Comparatively speaking, timeliness and cost are very important, especially in implementing. If the government and system capacities and capabilities cannot meet the needs and requirements, we would be less effective and less efficient, maybe less feasible. The citizens' role is also crucial. Compliance in a passive meaning, co-production or cooperation, or participation in more active meaning, whatever. Their role is very crucial. Still, if focusing mainly on Korea, we don't have answers to many questions. Taiwan is different, but although we are not much debating, we do not know elimination is achievable or feasible. When and how, we do not have ideas. Now more people are complaining that social distancing is no longer possible, mainly because of economic reasons. We do not know how we compromise and eventually whether it could be sustainable or not. Many ethical and justice issues are ongoing and not settled down yet. One of the challenging questions is how our responses can be decentralized in the future responses. We have learned that for a nationwide outbreak like COVID-19, decentralized and tailored approaches have to be taken. The issue of what could be done and how in the environment of widening demographic and socioeconomic inequalities between localities. Finally, we should discuss the next step of preparedness, particularly from the public health system perspective, including governance, resources, knowledge base, and information system. I'm feeling that battlefield would be the conflict between the mainstream market principle, even in the area of healthcare and public health, and the non-commodifiable public health emergency preparedness. Thank you for your attention.
Thank you very much indeed, Chang-yup. It's really wonderful to hear from you in South Korea, and thank you for making this time. I'm going to now hand over our last session to Stefan Baral, who's going to talk about Canada, but he's actually based in the Johns Hopkins Bloomberg School of Public Health. Stefan, over to you.
Great, thanks very much. Just quick confirmation, people could see my slides?
Yep, very good.
So I'm going to be taking a little bit of a different approach, but I think very complementary to what we just heard. I'm going to be speaking quickly because I want to talk about a lot in a very short period of time, but I'll talk a little bit about outcomes of restrictions-based COVID-19 strategies in Ontario, Canada. I'm representing Dr. Mishra, who is the PI of this work, and a lot of co-investigators. I am a co-investigator, just in terms of disclosures, on an NIH and CIHR funded project. I take no personal salary for either of those. I have no financial conflicts related to COVID-19. Similar, actually, I've not signed any declarations, memos, etc. I will note I grew up in Sweden. I'm Swedish, so I don't know if that's a conflict or not. But so I'll just say, very briefly today, I'm going to talk about structural racism as a baseline driver of disparities in COVID-19. I'm going to talk about the very rapid transition that happened, the epidemiologic transition of COVID-19 in Ontario, Canada, the outcomes that we've seen in terms of restriction-based intervention strategies, and then what would it mean to achieve equity and impact in the COVID-19 response, i.e. what would it mean to actually achieve the lowest possible burdens of COVID-19. I'm going to start by presenting data from AMFAR. These are data from the United States, which show that historical segregation and structural racism are hugely predictive of where cases have been, that in the least diverse areas, you've seen the least amount of diagnoses and associated mortality, and in the most diverse areas, you've seen the most. And that is a great paper about the history of redlining and how that has really resulted in the context that our in place today that have really driven so many of these disparities. So that is in terms of living conditions. The second thing that structural racism obviously plays out is in terms of working conditions. And so, this idea of essential worker status has been critical. And I think many of us know that meatpacking plants, for example, were deemed essential in order to just feed the needs of so many other folks, but obviously with grave risks associated with that. And I think nice paper to show that. In Toronto, I think it's really important to note, and I saw from Professor Baker's presentation a similar transition. We had a very rapid transition from travel-based cases, which were predominantly higher income, less racialized communities between January and March 2020, to an extremely, disproportionately affecting lower income areas with local transmission. And so what was so interesting is that those epidemics almost feel like two very distinct epidemics in terms of who was flying in from Switzerland and from their skiing vacations, and then ultimately where local transmission came up. And you can just see these extreme disparities. And in fact, those disparities have worsened over time in terms of local transmission. Don't have the opportunity to talk about that today, but it has been a consistent trend where we've seen further concentration. So what have COVID-19 restrictions done? So this has been the sort of idea of a COVID-0 approach, either in specifically named as COVID-0, alternative names include no more waves and others. But what have been the outcomes of these in Ontario to date, using actual data? So one of them is, we can first look at mobility. So if you look at mobility pre-March 2020, local transmission, you saw that actually these are percent of devices that stay home by income level in the Greater Toronto area. What you can see is that it's basically equal. If we go in a little bit, you can see actually some differences where higher income folks are more likely to leave their homes. But rapidly, in the context of lockdown orders, you see that the highest income folks, which are the highest quintile, the quintile 5 here, were much more like relatively almost 200% more likely to stay at home compared to those that are in the lowest income status. And that there's a dose response relationship that goes accordingly. And you've been following that. We can dig in on any of one of these regions, but in the context of our second wave and our second lockdown, that has absolutely been the case, that we've seen those that are highest income most likely to be able to stay home or most likely to stay home, and those that are essential workers, et cetera, to not. Again, this is by income level. We can see the exact same thing by essential worker status. These essential workers here is defined as people who cannot work remotely. These are folks who keep our power on, our internet on, our groceries filled, our pharmacies filled, our gas stations filled. These are folks that are keeping society afloat for the rest of us. And physicians, as a practicing in-person physician throughout this time, I'm not sure if but nonetheless, it is to note that essential worker status, that those folks were the least likely to stay home. And thus we can assume that there was some increased contact rates associated with that. So what does that then look like? These are case numbers by basically the percent of Toronto by visible minority. I think similar to what we've heard in some of the earlier presentations. We saw actually in the travel-based cases in early February and March, we saw that, like less racialized communities were more likely to be affected, again, related to income status and travel. But that rapidly shifted in the context of the first wave, where the most racialized communities were most affected. And in the second wave, you can see that while less racialized communities have been, obviously rates have increased, those have been extraordinarily high among racialized communities. But why is that, right? There's nothing biological. I think the biological hypothesis has been beaten down and is over. And so we can also see the same relationship by income status, that in the first wave, the most economically marginalized communities were most affected. And then again, that you've seen this, what people are calling a K recovery, where, lowering just, borne the extreme burdens associated with COVID-19, both cases and deaths, I'll note, these are cases in these areas. And then as it relates to living conditions, the same thing is absolutely the case, that those that have suitable housing, which is defined as having at least one room per person in a household, have obviously had increased cases during this time, but nowhere near those communities that have had, that have not suitable housing. And then the final dynamic where it's the most clear is essential services. That is the communities of folks in the Toronto area that are keeping society afloat have borne the brunt of this epidemic in terms of cases and mortality. And I hope we never forget that. I just, we won't talk about it so much right now, but I hope that is a lasting legacy of this particular response and what we've done here. So what is it that we would have needed to have done? I'm just going to talk I know modeling has been popular in the context of COVID-19, so we've done some of our own. Because I think traditionally we thought about a restrictions-only response. And I'll note that a restrictions-only response showed to decrease the contact rates in the higher risk areas, those areas I just talked about with more essential workers and lower income, by about 10%, but lowered contact rates in higher income areas that were already lower risk by about 25%. And so, when we looked at this most closely, what we've seen is that unless we actually resource the lower income areas and more economically marginalized areas and more racialized communities to be able to decrease their contact rates in an equitable way, we're going to continue to see this prevention gap, that if we treat it as like an all lives matter response, and we do not pay attention to the particular vulnerabilities among particular communities, and we don't resource them in order to address those risks, we will see this prevention gap where everybody's more affected by it. And that it is only in those scenarios where we really dramatically lower the contact rates in the most economically marginalized communities, which is the maroon and the orange lines, to decrease their contact rates by 50 to 60%, that we actually achieve this idea of COVID zero. But I will note, we did none of that. We only focus on restrictions. So 8 minutes, as promised. Some concluding thoughts. I get it. When we first started these models, we pretended everybody was at the same risk, even though we knew that wouldn't be the case. We knew that structural racism and socioeconomic inequities built into our society, so many of our societies, would drive some folks to be at higher risk and some folks to be at lower risk. And if it had been homogenous, that we were all at the same risk, then maybe restrictions would have delivered equity and outcomes, but they obviously have not. And I don't think they have in any part of the world. And I would be interested to see, even in terms of local transmission in New Zealand, who's been affected and why they've been affected, I think is an important element. I'll note the same findings have been seen in Sweden, Canada, et cetera. Restrictions have concentrated infections and mortality in lower income and essential worker communities. And again, we did nothing for that. We've done very little for those folks. And as we look at mobility, what we can see is that we've squeezed out whatever decreases in mobility that we can with our restrictions-based approaches. And the folks that continue to move and thus have contacts associated with that movement are folks that are keeping society afloat. So the sort of finding, and I can say this as a Canadian, I feel comfortable. I often work in places where I don't have agency, but I will say as a Canadian, we cannot restrict ourselves out of COVID-19 in Canada. We have to transition to providing empiric services so that we can really improve outcomes for all folks and not just wealthy folks. And we need to try to transition to that idea of adaptive responses in order, because we've seen such incredible amounts of adaptivity and risk. Thanks.
Thank you. Thank you, Stefan. That was great. And thank you for sticking to time. I'm going to now hand back quickly to Phil because we're running out of time. And Phil, for the next session.
Well, yes, indeed. And thank you. Golly, what amazing sessions we've had. I think we've learnt now that you can't have zero COVID without zero inequality. Unless you address health inequalities, you won't get anywhere near zero COVID in the long term. So that's been a pretty impressive message. We're now going to talk about zero COVID and implications for childhood vaccination. Delighted to welcome Jenny Levine from Emory University. Hi, Jenny, how are you?
Hi, I'm doing well. Thank you so much
Good.
for having me. All right. Okay, can everybody see this? Ooh. I'm going to assume someone's going to tell me if there is a problem.
No, it's great. Great,
okay.
Jenny.
Fantastic. Thank you. Okay, so I am a researcher at Emory University. I do infectious disease research, and we have been thinking a lot about what might happen in the somewhat longer term future of COVID. I work kind of at the borderline of within host immunology and between host transmission of infectious diseases. And one of the key things that we have been focusing on is how does immunity get developed and then how does it wane? And how does that affect transmission and disease separately? So I'm presenting here a model that we've sort of implemented based on data from a variety of coronaviruses that suggests that someone begins naive. And so at the moment, of course, we have not at the moment, a year ago or just over a year ago, we had a global population of people who were completely completely naive to SARS-CoV-2, immunologically naive. And we use a model based on these data that assumes that people get infected and that can reduce transmission at the beginning, in fact, possibly even eliminate transmission for some time. But as immunity wanes, the functional aspects of immunity change. And so people may still have immunity that prevents disease, that possibly reduces transmission, but it doesn't completely prevent transmission anymore. And so from looking at a combination of studies on endemic coronaviruses and then recently preliminary data on SARS-CoV-2, our best guess is that there is a short period following a primary infection or a vaccination when reinfection is unlikely. And this is thought to be maybe a year, maybe not even. And there's a number of different studies from these different viruses suggesting that. And then people do get reinfected. Certainly with the endemics, we have lots of evidence of reinfection, and even with SARS-CoV-2, some evidence of reinfection. Viral shedding may be for a shorter time period, but most importantly, the disease seems to be more mild. So an initial infection, or hopefully also an initial vaccination, leads to short-term transmission reduction, but long-term disease reduction. And so here's just a little bit, I'm just gonna these are some data that came out in the past couple of months on SARS-CoV-2 in particular. You can see 1 to 2 months after infection with SARS-CoV-2, people had sort of all 5 of these components of immunity for the most part. And by 5 to 8 months, some of their components of immunity were waning, but they retained some. So again, this idea of immunity as a dimmer switch, not an on or off thing. We can also sort of compare this with other infections. And in particular, you might look at measles, which has been really highlighted as one of the infections that we have been able to very strongly control, even locally eradicate in lots of places. And one of the things you'll notice about this is that the duration of immunity to measles appears to be very long compared to most other infections. So the time to loss of immunity, over 75% of people in this sample still had antibody titers that were protective 100 years out. So this is saying, yeah, it makes sense that we can locally eradicate measles because vaccination in childhood provides this very strong protection. But when we look at SARS-CoV-2, it's a very different story. The other really important key piece of information we've been focusing on is the age specificity of the infection fatality ratio. And so over here, you can see this red line is the infection fatality ratio for SARS-CoV-2. You can see for SARS-CoV-1, it's the same shape, but much, much steeper. So people get much sicker, but you still see very low infection fatality ratios in young children. In contrast with MERS, this is a very different shaped curve, and you do get severe mortality in young children, which has its own consequences. And I now want to just highlight, because as time has gone by, we've found that the infection fatality ratio for SARS-CoV-2 is not the same in all places. It can actually vary quite widely. So this blue line corresponds to this blue line here. But you can see now in other locations, SARS-CoV-2 can have different age-specific fatality ratios. They can vary very widely in older people, but the infection fatality ratio in young children remains very low globally as far as we've been able to see. And again, I just want to kind of contrast this with some other infections. You can see here's measles again. So we saw that immunity to measles is very long lasting, and there is this bump up in the infection fatality ratio in young children. Similarly, in many other infections, in polio, in pertussis, even in the H1N1 1918 Spanish flu pandemic, you see a bump up in this early infection that you do not see with SARS-CoV-1 or SARS-CoV-2. And this is really promising because what it suggests is that as long as an initial infection or two or initial vaccination or two provides strong disease-reducing immunity, in the long run, we are likely to enter this mild endemic state, this where people are the only people getting a primary infection are young children. Now, of course, to get there, I think everybody else today has really been talking about all the details of getting there, and I'm not even touching on that, and I'm no expert on it. So I'm not so much making any statements about how we get to this place, but that once we get there, the natural dynamics of the infection may well allow for this to be very mild. And to get there, we need high vaccine coverage high vaccine coverage is the short answer. The alternative is high levels of infection, but high levels of infection come with, of course, massive hospitalizations and deaths. So what do we need to be true for this mild endemic state to happen? First of all, the first couple of infections or vaccinations need to provide strong and long-lasting disease-reducing immunity. And second of all, child infections have to remain very mild. Thus far, that's what we've seen, but we need to keep monitoring that. And just to kind of real quick summarize here, the knowns, antibodies against SARS-CoV-2 wane much more quickly than measles. Partial immunity exists for other coronaviruses and is likely for SARS-CoV-2. Primary cases in children have a very low infection fatality ratio. Primary cases in adults, however, of course, can be deadly. So are reinfections in adults mild? This is a huge question that we need to be answering. And similarly, are infections post-vaccination mild? How many infections or doses of vaccine are needed for strong and long-lasting disease-reducing immunity? And we need to be watching this infection fatality ratio in young children. Will the new variants continue to have the shape of the curve we see for SARS-CoV-1 and SARS-CoV-2, or might they look more like MERS or measles, where you see an increase in the infection fatality ratio in the very young? A couple other questions that I have up there, but I will leave it at that for the sake of time.
Thanks very much, Golly. That was very well kept to time. Thank you very much for that. And there will be questions at the end of the session. So thank you. I'm going to go straight on to the next session now. We're talking about possible futures for the UK. Chairing it is Kamran Abbasi from the BMJ. Over to you, Kamran.
Thanks, Phil. I had very high expectations for this event today, and I think all the speakers so far have exceeded them. So thank you very much. I've got no doubt that the following two speakers will really keep up those standards. The question now is, what happens next? What are the possible futures? It's hard enough predicting the future, but when you don't know what the current strategy is it elimination? Is it control? How do you then predict the future? I think we can be sure the UK strategy isn't elimination at the moment. It's some sort of control, possibly protecting the health service as well is a primary thought. But over to Christina Pagel first, and then George Davies-Smith to help us answer these questions about the future. Christina, over to you.
Hi, yeah, no pressure there on me. So, right, let me share my screen. So I hope everyone can see that. So I'm really talking about two possible futures that I see kind of at two extremes. And I will be saying why I actually think that a zero COVID approach is the best thing right now. And I'm talking about this year because I think the future is so uncertain that we just don't know what's going to happen. You know, I cannot predict January 2022. So just where we are now, you know, cases have come down a lot. They're still going down. This is good news. Hospitalizations are coming down, deaths are coming down, and vaccinations are going up. This is actually slightly out of date now. I think it's about 35% of UK adults have now had at least one dose of vaccine. There's also good news from vaccinations is that there's growing evidence that they do reduce transmission. That's all the vaccines that we're using here do reduce transmission, not 100%, but significantly. There's also emerging evidence that they are effective against all current known variants of concern. This is from Pfizer, but I believe that there's similar data for AstraZeneca as well. Although I will just say there's new data coming out that one dose is less effective in cancer patients. So that means that things could go well. So this is kind of an optimistic future for the UK. This is if everything goes well. So if schools and further reopenings don't push R above 1, That would be good, given that there's current low prevalence and high vaccination. And then the hope is that by the end of the summer, there would be hardly any restrictions in place. The majority of adults are offered a first dose of vaccine by mid-June. That seems quite likely. And that a majority of adults are fully vaccinated by September, also seems likely. And I hope that children can get offered the vaccine in the autumn. Israel is starting to vaccinate teenagers already. Again, the optimistic future would be that no vaccine-resistant variants emerge in the UK or imported into the UK, that cases get near zero without further effort, because nothing pushes R above 1 and we have low prevalence and high vaccination, and that if there are occasional outbreaks, they're quickly controlled. And that's where we are for the rest of the year. And that vaccination, even if some people get infected, ensures that hospitals are never again overwhelmed. That's kind of the optimistic future for the UK. Now, I really want that future. I want it so much. But I think that a strategy that aims for zero COVID, so aims for no community transmission or minimal community transmission for this year, makes this future so much more likely. And I'm going to spend the rest of the talk kind of explaining why I think that. So firstly, schools. These are kind of a big unknown. We'll know a lot more in about a month. But cases rose in the southeast during the November lockdown, which is the same as this lockdown, except schools are open. And this is where we had the prevalent Kent variant. So we know that under kind of similar conditions to now, with schools open, things went up. We also know that children and most teachers and parents have not yet been vaccinated. So Anne Sage felt that opening schools with primaries and secondary schools together was very likely to push R higher than 1. And in fact, they felt that a phased reopening would allow a safer reopening of schools, and that's what all the other UK nations are doing. So England is a bit of an outlier in opening both together. We will know in a few weeks how that's going. But this is a risk, right? This is a risk that we are now going to start cases increasing again, when actually the large majority of people under 50 have not been vaccinated. You can do things about this. You can make schools safer. This is a beautiful diagram from a paper published in The Lancet this week, led by Deepti. But at the heart of it, at the heart of all of these measures, is this control community transmission. So schools, in some ways, has become a bit of a toxic subject for reasons that I find difficult to understand. But the one thing that we do know is that wherever community transmission is very low, schools are pretty safe, that you can keep them open, that very few children ever have to go home and isolate, that it's very undisruptive, that keeping community transmission low is the way to keep schools open. New variants is a risk. So far, our vaccine seems to work well against all variants of concern. That's a really, really good thing. But the selection pressure on COVID to resist vaccines is going to increase over the summer. This is a figure from one of Adam Kaczarski's papers on showing kind of how the viral adaptation rate depends on immune pressure. So kind of the strength of selection, how many people are resistant to current strains, and that's through vaccination or through natural immunity, and how much virus there is around. So basically, as more and more people get vaccinated, you're creating an environment where any mutation that lets COVID infect people who've been vaccinated has a big advantage and can spread because it can just infect a lot more people. However, the less virus there is around, the less opportunities there are for those mutations to arise. Now, this is an increased risk when millions of people, as they are in the UK, are partially vaccinated because we're doing a delayed second dose strategy. I happen to think this was the right strategy given where we were in January. However, there is that risk that when you only have one dose, it might be slightly easier for a mutation to evade the vaccine. And a zero COVID approach this year is the best way to reduce this possibility, because we're on this line, we're on this kind of, we're increasing the vaccination this summer. And if we can get to near zero COVID, we're basically down here because we've reduced viral abundance. We've also heard people saying, that COVID might well evolve to become another seasonal cold type coronavirus. I'm not a virologist. I mean, that would be great. but over what timescale, years, decades, and I think the previous talk suggested it might be 2, 3, 4 years given certain assumptions, but it's very unlikely to happen again this year.
1 minute, Christina.
Okay, all right, in that case, I'm going to go for just to say that border control is a big issue. Now, deprivation, actually, I could have taken these slides out because Stefan gave a fantastic talk about this in Toronto, but we see exactly the same patterns here, that deprivation is a big, big driver of COVID, and people cannot currently afford to self-isolate, and so they don't get tested and they don't self-isolate. And we're seeing this in England now, that areas with high deprivation also have high pockets of cases. We're also seeing that people aren't getting vaccinated as much in more deprived areas, particularly in younger age groups. So for shielding people now, there's a massive gradient. Only 56% of people in most deprived areas who are shielding have been vaccinated compared to 80% in the least deprived areas. This means there are a lot of vulnerable people in deprived areas potentially this summer. And we also have a strong ethnicity gradient in vaccination. You cannot rely on vaccination to do everything. So I think, when people say COVID is going to become endemic, or we can achieve control of it, what that means is you're pushing the burden of disease onto deprived and disadvantaged communities. I personally do not accept that as a trade-off, but whether I do or not, I think this year, while we're rolling out vaccination and in the face of the emergence of new variants, allowing sizable outbreaks is just such a big risk. As Stefan said, addressing this requires support and not further restrictions. But in the long term, COVID has highlighted the need for public health to lie at the heart of all policy. So the pessimistic future is that all of these things happen and we end up with a new vaccine-resistant variant, and that we then end up with a severe third wave in the autumn and winter of this year, with more lockdowns until we can get booster vaccines deployed and developed. So summary, last slide. I don't know what the world's going to look like in a year's time. I don't know how many countries will have mostly vaccinated populations. I don't know if there'll be new variants that will resist the vaccines. I don't know if children will be vaccinated. I don't know how much more we'll know about long-term impact of COVID. We've not heard that much about long COVID, but it is becoming increasingly recognized as a big problem, even in children. We will have learned a lot more about how other countries have dealt with COVID over the next winter. And it just seems to me that a zero COVID approach this year, this summer, for the next 9 months, 10 months, puts the UK in the best possible place to reassess next year, when we have a fully or near fully vaccinated population, minimal COVID, and so much more knowledge. So to me, getting to near zero is achievable. There's not that much effort. And I just think we'd be crazy to allow high prevalence this summer just because we can't quite be bothered. And I'll stop there.
Great, Christina, thank you very much. Good to hear some optimism, although it did come with a heavy proviso. Without further ado, over to George Davey-Smith. George.
Thanks. Sorry. Hopefully you can see that.
Yeah.
Okay, so I'm going to talk about futures too. I'm going to talk about what we need to know. This is a sort of known unknowns talk. The information I think we need to be able to think about how to get to the optimal possible future is we need to know about the effects of SARS-CoV-2 infection. That's probably the one thing from my lists that we do know about, this huge age relationship with how badly people do with SARS-CoV-2 infection. We need to get reliable data on long COVID. That means data that aren't just floating numerators, like some data from the ONS survey on children that have been reported widely are. We need to get properly epidemiologically collected data about the degree to which this disturbs people's lives. As Jenny talked about, we need to know the duration of immunity following infection and vaccination, and we are getting knowledge on that, and it is, as Jenny points out, very likely to be short. We need to know about the willingness to be vaccinated and who will be willing to be vaccinated over the long periods of time, and the sections of the community who will not be vaccinated, and who will therefore become at risk of getting serious illness with any infection circulating. we need to think about the evaluation of the trade-offs. And I think this should be thought of as lives versus lives rather than lives versus the economy. All forms of interventions influence people's lives in a deep way. And it'll be an individual phenomenon. How you actually weigh those things up is the crushing loneliness for some people, how they would weigh that up against potential reductions in risk from a particular disease. And that should be evaluated across society, not just in particular groups. And we really need to know the effects of long lockdown. We've heard about long COVID, but what are the long-term effects on young people who have been out of education? What are they going to be over 20 years, 30 years? We've really got to think about that. And we've got to realize that what's been happening over the last year has been a massive intergenerational transfer of the harms and risks transferred from affluent older people onto working class youth. If your kids are in private education and you can work from home, lockdowns are fine. If you actually have a job or you have to go out, if you're a delivery driver who's facilitating the lives of people happily working at home, then that isn't fine. It's not fine for your kids and for your kids' futures. So we really should think about that and how that is magnifying inequalities and is going to magnify inequalities into the future, not just now. Then what do we need to know about the virus? We need to know about how the virus is going to change due to just drift. Viruses do just change and there's no selection going on. But then we need to know about how the virus will change due to selection against the background of natural infection. And I'll come back to this. How the virus may change due to selection against the background of vaccination induced by immunity. Christina just talked about that as a real issue that we really do need to know about. And then how the virus will change against the background of a mixed immunity of circulating infection and vaccination, with vaccination being changed to try to keep up with the changes in viral type. But we do know that it is likely that the virus changes as seasonal coronaviruses. Most of the 4 seasonal coronaviruses can be shown to change against the background of natural infection. But that endemic infection does actually constrain any disease in the way that Jenny talked about when people get infected a second time and a third time after the new arrival of a new infection. It has been known for years that generally the disease severity is reduced substantially. But I think most importantly, what we need to know is about disease ecology, which is how the virus and the human populations act together. We need to know about the construction and levels and distribution of population immunity generated by vaccination, generated by the circulation of virus, and generated by a mixture of the two. And in particular, we need to know how that immunity matches to the current viral types. With the seasonal coronaviruses, and as I say, this is from decades and decades of research, as with natural immunity, as the germ changes, that natural immunity changes to match the changing germ. Where with vaccination, if you're relying entirely on vaccination immunity and think that that can keep infection out of the population entirely, you're playing catch up against changing viral types. I'm going to go back now to the 1930s and Sheldon Dudley, who did seminal work on diphtheria immunity and immunity to many diseases. And Dudley came up with what he called Burnett's law, which seems to match very well with what we've seen with SARS-CoV-2. But within endemic areas, the virus is ubiquitous and infects the infants and young children, causing the majority of subjects unapparent or mild clinical infections, followed by a specific immunity which lasts throughout adult life. But when new diseases arrive, as we've seen with the arrival of SARS-CoV-2, on first arrival, the brunt of the epidemic falls on the adult members of the herd, as we've seen, obviously, in this case, and the infants and the very young appear to be relatively non-susceptible. But then that is the transition then is to the endemic situation. Another aspect of disease ecology that Dudley discussed, and many others have discussed in the 50, 80 years since, are virgin soil epidemics. So these are epidemics in populations which have not experienced a disease for a long period of time. For example, Polynesian islands and Fiji and places that when measles arrives, it hadn't been there for decades, is suddenly a very serious condition, killing many adults with high mortality. As Jenny pointed out correctly, measles has very long-lasting immunity. You obviously see virgin soil epidemics are much sooner to become possible with diseases like influenza when the immunity lasts much less long. Now, when you look at the seasonal coronaviruses, these are data from the US, and these are the 4 seasonal coronaviruses, and they peak in January and December, January every year, and this is what is seen in CDC data. That's expected to be seen. They come every year. Each year, one of them is higher than the other, but each year as the infection arrives, the immunity of people who've been infected previously will be boosted without them becoming seriously ill. But this year in the US, the seasonal coronaviruses, because of what's been obviously done, although not completely successfully in the US, to restrict SARS-CoV-2, the seasonal coronaviruses have not shown this pattern. So people are now going to be going longer than they, in general, they ever would without getting infected. We know that at 1 year, the inoculation studies done many years ago with seasonal coronaviruses, people get much less sick if they've been previously infected. But as that time goes on, we move towards the virgin population situation. And maybe in particular in communities which are with restricted entry, such as long care stay facilities, people will be getting to that stage. And in the past, probably just by chance, some facilities where they have not had a particular seasonal coronavirus for a particular length of time, there are reports of increased mortality, which when they're investigated, all that can be found is seasonal coronavirus. These reports are so this is some situation that might be created when you interfere with disease ecology in the way that it is interfered with. So in the long run, I'll finish in 30 seconds. In the long run, we are aiming for near zero COVID, and COVID deaths is very different from aiming for zero SARS-CoV-2. And we should think about those two things separately. The optimal long-term vaccination strategy is unclear. Like Philip Larkin, I have the jealousy of those who have faith. It would be great to think there's a simple solution, but I really think there's so many things we don't know. But there's 2 things I do know. Measles is not a good model for SARS-CoV-2. And I know that thinking of human bodies, as this tweet I put up here discusses, simply as viral vectors and selectively closing borders, which have a huge influence on society and how we think of others, has a terrible history. Thank you.
George, thank you very much. That was fascinating. Taking us back to the future. Our immediate future is Phil and trying to get through your questions. Phil.
Yes, well, that's the recurring theme of these fabulous webinars, is that we run out of time for questions. So we've got one for each section, and I think Nikki is going to give us our first one for the, presumably for Deepti and John. Is that right, Nikki?
So for the first one for strategies, so for art.
Oh, art is it? Art, yes. What's your question for art?
Yeah, so why should we aim for zero COVID when we don't bother to aspire for zero flu?
Well, can you hear me okay?
Yes.
I'm coming through. Well, yes. I think that's a great question. The hope is that we can achieve zero, or at least do better with COVID than flu, because it appears that the vaccines are much, much more effective against this virus than our current flu vaccines. So that might be one difference, but I would agree with you that for flu, we do a pretty bad job of reducing flu mortality every year.
Thank you very much. It's also interesting that lots of NHS doctors, including some senior consultants, don't routinely have the flu vaccine. Will they change their mind? Will it become obligatory? That's probably another webinar. Nikki, who's your next question to?
So for the for and against zero COVID, we've got, What do the panel think will be the collateral health costs resulting from pursuing zero COVID in terms of a lack of focus on non-COVID health matters, which appear to be resulting in a rise in excess non-COVID deaths, according to ONS?
I'm
happy to start with that.
Thank you, Deepti.
Yeah. So a lot of the lack of routine care and what we've seen, increase in waiting lists in the UK is essentially, and in many other countries, is essentially because of lack of containing COVID. Our health systems became overwhelmed. We had to go into long lockdowns so people couldn't access in-person care. Actually, if you look at countries that pursued zero COVID, they had short lockdowns, their health systems didn't get overwhelmed, and they were able to provide much more routine care because they returned to near normal life in a matter of 5 to 6 weeks in many cases. So actually the impact of health is not because of the strategy to pursue long COVID, rather it's lack of control of long COVID, which results in these sort of halfway measures or prolonged lockdowns and our NHS becoming overwhelmed repeatedly, which is what leads to lack of healthcare for people.
John, are you still there? Would you like to add your thoughts?
Sure, I think that the collateral damages could be 10 times or 100 times worse than COVID-19 itself. And unfortunately, we don't know. Most of them are not necessarily happening now. They're going to happen in the future. They have very prolonged kind of footprints or potential for footprints. Of course, we have also homeostasis in human populations. We're very resilient. We're able to forget. We're able to address difficulties. But I think that we need a holistic approach. We need to look at the big picture, all the dimensions. In some cases, some interventions may have more or less collateral damages, and we cannot ignore them. I think that saying that lockdowns actually contain COVID, I think is false. We've seen that in most countries that had the strictest lockdowns, they had the worst outcomes, both for COVID and also for the collateral damages.
So John, are you saying that you don't believe that lockdowns actually have an impact on bringing cases down? Are you actually saying that?
I think that lockdown, along with many other measures like very intensive testing, contact tracing, isolation, very early on, when you have a low viral load, when you have limited seating, you can do things amazingly well. And I think that these are success stories. But once you're in a situation with 2 billion people infected, prolonging lockdowns blindly just doesn't help. I mean, the data that we have, at least what we see is that they're pro-contagion. And I can see explanations for that. You just limit people staying at home for longer periods of time.
The data Michael showed is that zero COVID is associated with shorter lockdowns, not longer lockdowns. We've had the longest lockdowns in places that didn't manage to get on top of the pandemic. It's the zero COVID areas that have had the shortest lockdowns.
But that's a year later, or more than a year later.
You're going to have to continue this conversation on chat because we've only got 3 minutes left. It's really fascinating and I'd love another hour of it, but we need our third question, please, Nikki.
Yes, of course. So for the country case, the most popular questions were about border controls and vaccine passports. So sort of what will happen when New Zealand opens borders, or for Europe, are we going to need to remove freedom of movement? So what transnational cooperation will be necessary to achieve zero COVID?
Okay, who wants to take that? Transnational cooperation, what will be needed?
Well, I'd just like to comment that the World Health Organization unfortunately seems to have been absent in these discussions, and we're all looking to them to provide a global framework for how we can open borders. When New Zealand is opening its borders to other countries that have achieved elimination, but we would really desperately need, I think, some global coordination in this process. And obviously, vaccine passports are a very complex tool and may actually really be quite poor from a point of view, but ultimately I think they do have a place. But this is, again, we desperately need global coordination on this.
Stefan, did you want to come in?
Yeah, I mean, I just want to say two things very briefly. One, travel has actually been not so much of a big part of our story coming into Canada for the last number of months. I think obviously there's been a resurgence of border patrols for fears of variants, but actually in terms of overall case burden, it's been very low for almost a year now. I will say, and I want to say this very publicly, I worry so gravely about vaccine passports, about how it will affect the global emergence of economies and how it'll affect development in general, that it wakes me up at night. So it's not for today, but it wakes me up at night.
Thanks. We're going to have to quickly move on. Nikki, there's so much we still don't know, isn't there? What's your next question?
So the next one's about implications for childhood vaccination, and it's should children be vaccinated the way they are for measles, and what do we need to know and study before childhood vaccination is even considered?
Well, nice one for you, Jenny. Are you up for that one?
Sure. I would love to. Well, I guess, of course, I think the first thing is that we need, if we are considering mass vaccination of children, we need to test the vaccines in children. So that's kind of a no-brainer. But I would also say, and I kind of presented a bunch of data, that the idea of mass vaccinating children long into the future, such that we provide this long-lasting immunity that's going to lead to disease, at least local eradication, seems extremely unlikely because transmission blocking immunity is so much shorter. And than it is, for example, for measles. And then if we look at the severity of disease in children, I would say it seems like it may not be necessary and in fact may have a downside if we vaccinate all children instead of allowing for natural infection. And so what we do in the next few months regarding, or the next year even regarding vaccinating children, I think is more of a toss-up for me. But in the long run, it's hard for me to see, unless cases become more severe in children, why we would want them to be getting vaccine-induced rather than a natural infection-induced immunity to something that likely would be no worse than one of the other endemic coronaviruses in those children. So I guess the key things are to be measuring disease severity in young children and how that changes with variants, and looking at long-term consequences of COVID in young children. But if all of those play out the way we see, I would say we're not going to build up herd immunity by vaccinating children, and we're probably not really going to be reducing deaths either.
Thank you, Jenny. That was an excellent answer. Nikki, last question to George and Christina. What is it?
What impact do long lockdowns have on our immunity, and what are the effects of suppressing the virus, e.g. on emergence of variants or reduced immunity on re-entry to the community mixing? What can we learn comparing countries that have and have not locked down hard?
Ooh, who's going to take that? Christina or George? Who's going first?
Well, I can go first in the sense that is definitely outside of my expertise area. So I feel as if anything I say would be no more than a kind of informed amateur. And I think, it's probably a good thing to be able to say, you know what, that's not something I feel comfortable answering, rather than try and pretend that I know about that kind of thing. I'm afraid that's not very satisfactory.
Oh, okay, I'll ask you something different then, because that's quite. Do you think the public would understand the message of zero COVID, even if they couldn't define it particularly? Do you think it's easier for them to understand? If you said, as you're implying, we should try it for this year only, do you think the British public would buy into it?
I think so. I think messaging it as cases as low as possible, get it down and keep it down, or kind of a zero fire approach where you don't live with a bit of fire in your living room. I mean, I think people can understand it, and they have understood it across the world. It's not as if no country's achieved it. This is what I find a little bit odd, is that there isn't an example of countries that are successfully living with it. So and I think if you give people a time scale and give them a payoff, and the payoff is that we don't have to lock down ever again, and we emerge into 2022 in probably one of the best positions in the world, then I think people would be happy to do it. I think we've consistently underestimated the public this whole year. Okay, George, do you want to add anything to that?
Well, I would just say that the idea that we just lock down once and then it's fine, and that in a disease which is absolutely certainly endemic on a world scale, then we need to think about what is a long-term future for countries which are actually trying to keep the virus out of the country. Are we talking about testing to come in? Are we talking about quarantines for the long term from people coming from countries which will absolutely definitely have SARS-CoV-2 circulating? Or do we look to a future strategy of the sort I think Jenny was pointing to, about vaccinating, obviously, the people who are at high risk of doing very badly with the condition, and maybe vaccinating kids, maybe after absolutely, as Jenny says, after we have data on effects of vaccines in kids in the short term. But, and I really think we need to think very differently about zero SARS-CoV-2. I do not think is a tenable strategy when at a world level, SARS-CoV-2 is certainly endemic, and unless we want to have permanent border closures and have a world like that, unless we want that, we've got to think of a strategy that moves towards the ways of thinking about how optimally to develop immunity in a population with a mixed vaccine strategy that Jenny so nicely presented.
Okay, and finally, bigger picture, do you think generally the democratic countries that were better at managing health inequalities have been better at managing COVID? They've got better public health systems and they care.
Yes, there you go. Simple answer. Simple.
Thank you.
I say yes too. So we agree on that.
We agree on something. That's a good one to end. Our next known unknowns in 2 weeks is on variants. There might be some new variants in 2 weeks. Who knows? Thank you so much for joining us. Thank you for all our participants, and hope to see you again in 2